All right, let's get right into it. Picture this. You're in the hot seat for your Viva, and the topic is developmental dysplasia of the hip, specifically in a child who's already walking. The examiners are going to hit you with questions about pelvic osteotomies, and you've got to have a really clear, structured answer. So that's what this is all about, getting you prepped to nail that exact conversation.
The first question you're likely to get is always the most fundamental one. Why are we even doing this? Why perform a pelvic osteotomy at all? How you answer this really sets the tone for everything else. It's not just about making an X-ray look pretty. It's about that patient's long-term future.
And here's the core of that answer. The goal, our primary goal, is to restore normal anatomy and mechanics to the hip. We do this to either completely prevent or, at the very least, postpone the onset of osteoarthritis. We're trying to give that person as many decades as possible on their own native joint. That's the principle that drives every single decision we're about to talk about.
So, here's how we're going to tackle this. First, we'll cover the basic principles and, importantly, the classification. Then, we'll dive deep into the two main types, the reshaping and the redirectional osteotomies. After that, we'll look at the evidence. What does the literature say? And finally, we'll pull it all together into a solid decision-making framework for you.
Okay, first things first. You have to be able to classify these procedures properly. They are not all the same. And showing the examiner you understand the fundamental differences right from the start is absolutely critical. Let's lay out the three main groups. So I want you to think about it in three big buckets. First, you have redirectional osteotomies. These physically move the entire socket. Then you have reshaping osteotomies or acetabuloplasties, which are more about bending a still flexible socket into a better shape. And finally, you've got salvage procedures like the Chiari, which are really for when a good concentric reduction just isn't on the cards. For this talk, we're going to focus on those first two. Let's start with the acetabuloplasties. These are really elegant procedures. They're designed for the skeletally immature patient, which means we can actually harness the child's own growth potential to our advantage. The key phrase here is incomplete. We are not cutting the pelvis all the way through. Instead, what we're doing is creating a hinge. We bend the roof of the acetabulum down to get better coverage, and then we pack some bone graft in the gap. Because we leave the back part of the bone intact, these are inherently stable. And the whole thing hinges, quite literally, on having an open and flexible triradiate cartilage. This is a fantastic slide because it shows you the differences so clearly. If you look at the top row, that's the view from the outside of the pelvis. The bottom row shows you the view from the inside. You can immediately see that the cuts for, say, a Pemberton versus a Dega are different. And that leads to the critical difference, the hinge point, which is a classic Viva question. And this is the money slide for your exam. It's all about the hinge. For a Pemberton, the cut goes towards the triradiate cartilage. That's the pivot point. For a Degas, the cut actually stops short, leaving the posterior part of the inner pelvic wall intact. So that posterior cortex becomes the hinge. It's a subtle but really important difference that dictates the type of correction you can get. So if you're asked, talk me through a Delega, here are your key steps. You start by marking your cut on the outside, a curve running from just above the AI eyes backwards. Then, and this is super important, you use a guide wire under fluoro to check your path. You've got to be sure you're staying well above the triradiate cartilage. Once you're set, you cut the outer cortex, then the front and middle parts of the inner cortex. But you carefully leave that back third or quarter of the inner cortex completely untouched. That's your hinge. That's your stability. So when do we actually choose one of these reshaping procedures? Well, the indications are pretty clear-cut. The child needs to be old enough, usually walking age. The triradiate cartilage must be open and, crucially, still plastic enough to allow that hinging to happen. And while the ideal window is in younger kids, the evidence shows they can be done effectively all the way up to age 12 or sometimes even 14. Okay, let's shift gears to our next big category. What happens if the triradiate cartilage is closed, or if the deformity is just too significant for a simple reshaping? Well, that's when you have to think about reorienting the entire socket with a redirectional osteotomy. Now, this is a whole different ballgame. These are complete osteotomies. We're essentially freeing up the acetabulum as its own piece of bone and physically moving it into a better position. Because we've cut all the way around it, that fragment is inherently unstable. It absolutely has to be fixed with screws to hold it in that new, corrected spot. And this quote is just perfect. It beautifully captures the whole philosophy behind the modern workhorse procedure, the Bernese periacetabular osteotomy, or PAO. This is from Professor Ganz's original paper. It's all about that strategic reorientation, but the key phrase is preserving the structural integrity of the posterior column. That's the secret sauce, maintaining the pelvic ring. So, for your Viva, here are the key takeaways for the PAO. Indication: symptomatic dysplasia in adolescents and young adults after the triradiant cartilage is closed. The technique involves a series of very precise cuts. The massive advantage is that you preserve that posterior column, which protects the blood supply and allows for early weight bearing. The big downside? It is without a doubt one of the most technically demanding operations in all of orthopedics. Look, any consultant-level answer has to be backed up by some evidence. So let's take a quick look at what the literature actually tells us about how well these different procedures hold up over time.
So let's start with the Dega. This retrospective study looked at 48 hips and found that a well-done Dega osteotomy gets you a concentric reduction in almost 94% of cases. That tells you it's a very, very reliable procedure for acetabular dysplasia in the right age group.
Now let's look at the redirectional group. This study on the Birmingham interlocking pelvic osteotomy, which is a type of PAO, shows about a 76% survivorship at 10 years, which drops to 57% by 17 years. And here, failure means they needed a total hip replacement. The authors point out that these results are pretty comparable to other PAO techniques out there.
And what about the Bernese PAO itself? Well, some of the early results from major centers showed a really encouraging 92% survival rate at 3 years. But, and you have to mention this, the authors are very clear that this comes with a huge learning curve. The complication rate when you're starting out is not something to be taken lightly.
Okay, so we've talked about the types, the techniques, the evidence. Let's put it all together now. How do you actually decide which procedure to use for which patient? This is the synthesis part that really demonstrates that consultant-level thinking.
Honestly, this table is your ultimate cheat sheet. The single most important factor, the fork in the road, is the status of the triradiate cartilage. If it's open and plastic, you can reshape. If it's closed, you have to redirect. It's that simple. And from that one decision, everything else just falls into place. Reshaping is stable. Redirecting is unstable and needs fixation. One is for young kids, the other is for teens and adults. If you can articulate this clearly, you have absolutely nailed the core of the topic.
And just to finish, let's leave with a thought about the future. You know, we've talked about these procedures as being in very distinct categories. But with 3D planning and patient-specific guides becoming more common, are those lines going to start to blur? Are we going to move away from choosing a DIGA or a PAO and instead start planning a truly bespoke, personalized osteotomy for each individual patient? It's a really interesting question, and it's probably where this whole field is heading.